Good evening to one and all. Thank you so much for joining for today's session. So today we have the next presentation of FCPI Infectious Diseases Society Forum. And the topic for today is antimicrobial loading dose and maintenance dose concepts. And will be taken by Dr. Saidulu Kanta. A short bio about the speaker himself. So Dr. Saidulu Kanta has completed his PharmD and is currently working as a clinical pharmacist in infectious diseases in PD Hinduja Hospital, Mumbai. He's an experienced clinical specialist with overall 8 years in experience in various clinical pharmacy specialists, including ID, ambulatory cases, and medication therapy management. He has 2 international pharmacy certifications, SIDP AMSP certificate, ASHP pain management certificate. He's also a review editor of Indian Journal of Critical Care Medicine. He's currently a co-PI for ICMR AMSP project and research associate for other projects, including anti-fungal stewardship, BCID2 panel impact on AMSP project. And current affiliations include Clinical Infectious Diseases Society, CIDS, and Federations of Clinical Pharmacists of India, FCPI. So welcome to Dr. Saidulu Kanta for taking this topic. So just a short intro on the topic. As we know, we have already had different topics for the discussion under IED forum, including the dose adjustments, renal dose adjustments, hepatic dose adjustments, and obesity, how to adjust the antimicrobial dosings on different scenarios. So here, I think this is the most important topic of all because knowing the right loading dose and the maintenance dose under different circumstances is very important because it's a part of renal dose adjustment itself that we need to know. Loading dose, we know how to do it, but the maintenance dose, we have to rightly adjust the dose in order to ensure appropriate use of antibiotics. So I think to get a clear idea, sir will be presenting on this topic. So thank you so much, sir, for taking this topic today. Shall I please request you to move on to the next slide, please? Just a couple of guidelines before we move on to the topic. So you can post your questions in the comment box and click the submit button. And the questions will be discussed during the Q&A session at the end. Next slide, please. Your feedback can be submitted with the box that is available below the comment box. The feedback form will be disabled after the session. Next slide, please. In order to claim the attendance certificate, you need to submit the feedback form. So, and will be available, that the certificate of attendance will be issued within the 14 days of attending the event. And in order to download the slides, you need to press the PDF download button, which is available in the top right side of the corner. So from there, you can download the PDF slides. So with that, I shall hand over the session to Dr. Saidulu Kanta. The session is yours, sir. Thank you.
Yeah, thank you for the introduction. So today I'm going to talk on antimicrobial loading dose and the maintenance dose the concepts. When it comes to the pharmacotherapy, there are always components like right patient, right drug, right time, right dose, right time. So we are going to discuss the right doses, how you gain the right doses in terms of loading dose and the maintenance doses. So basically, what is the loading dose? Loading doses are required to dose the required to immediately achieve the plasma concentration that is equivalent to the steady state concentration. If you see this graph, when I give the loading doses, I can achieve immediately the Cmax that almost all equal to the steady state concentration. Usually the steady state concentration we can achieve after like 5 to 6 of 4 to 5 half-lives of the particular drug. So, but it is always not identical to the steady state concentration. So basically it is a larger initial dose. And why, what is the background of loading dose? Why, when we give the loading dose, what is the reasons to give the loading dose? As part of ID, we are seeing the more critically ill patients. The patient come with sepsis and septic shock. They present as acute kidney injury, and sometimes they admit with the sometimes they admit with the pleural effusion LRTI. Sometimes they have a malignant pleural effusions and pericardial effusions and sepsis AKI. So, and sometimes they underwent the major surgeries. They have the surgical drains, continuous surgical drains, and hyperdynamic circulation. Some patients admitted with the traumatic brain injuries, and some patients with the cancers like blood cancers, they underwent different chemotherapies, and that can cause neutropenia, febrile neutropenia, and some burn injuries. So all these can cause increasing the volume of distribution of hydrophilic antibiotic, because of beta lactam antibiotics, very water sensitive antibiotic. So very hydrophilic antibiotics. So all these this condition can cause some change in the pathophysiological changes in the patient. It can lead to the capillary edema and third space phenomena. So this, because of this, these antibiotics can leak into the interstitial spaces, and it can lead to the increase the volume of distribution. And as well as because of sepsis and septic shock and fever, and so this patient, they have a high cardiac output, will put on the inotropes, and that increase the renal blood flow, and mechanical ventilation, aka all these things can cause increase the renal blood flow, and this can lead to the increase the clearance of hydrophilic antibiotics. And in AKI particularly, sometimes we can see the decrease the clearance of hydrophilic antibiotics. So when you increase the volume of distribution of antibiotic, so the whatever the standard doses you are giving, that become a suboptimal doses. So you have to give additional doses, that is called the loading dose. That should be balance the, and that should be achieve the required concentration. So that's why you have to use the loading doses. And the increase in the renal clearance of hydrophilic antibiotics, that's why we have to increase the maintenance dose of the hydrophilic antibiotics. And if the patient with the severe AKI, there you can decrease the dose of antibiotics, that is called the maintenance dose of antibiotics. So the factors can increase the volume of distribution. So base volume of distribution of hydrophilic antibiotics. Which are the factors can increase the volume of distribution? If you see the sepsis pathology, leaky capillaries and edema, and hypoalbuminemia, and fluid therapy like inotropes or IV fluids, fluid resuscitation. So all these can increase the fluid volume, total body water in the patient. So basically increase the volume of distribution, vasactive drugs, inotropes, fluid like fusion, SITs, any renal replacement therapies or ECMOs, media stagnatis, traumas, burns, cirrhosis. All these we discussed in the previous slides. All these things can increase the volume of distribution of the hydrophilic antibiotics. So they can lead to the high total body water conditions like cirrhosis, CHF, pregnancy, may increase the drug volume of distribution. They can lead to the lower plasma level, like suboptimal levels. And this particular condition increase the volume of distribution like antibody dilution in plasma and extracellular fluids. And if you see the volume of distribution, there are like multiple studies published in various journals, and they finally found that the only some particular antibiotics stays in the extracellular fluid, and aminoglycosides, penicillin, cephalosporins, carbapenems, and daptomycin. Because there's antibiotic volume of distribution is very less than 0.3 per liter kg. Any antibiotic, if the volume of distribution less than 0.3 per liter kg, then they can stay in the extracellular fluid. If this volume of distribution increased any reason like sepsis, whatever it is reason, they can distribute into the other parts of the body. We're going to discuss in detail. So and other if the volume of distribution more than 0.3, like 0.7 to 1 liter per kg, so they can distribute from the extracellular fluid to the total body water, like clindamycin, linezolid, and metronidazole, vancomycin. And there are a couple of antibiotics. They have volume of distribution more than 1 liter per kg. For example, you have the 670 kg per patient, like the volume of distribution is 70 liter. So that means these antibiotics not stayed in the center compartment. They are going into the uh, tissues like peripheral compartments, like body tissues. Examples like colistin, fluoroquinolone, azithromycin, clarithromycin, tigecyclines. So these antibiotics have very high volume of distribution. And if you come to that main topic, like beta lactams, volume of distribution in ICU patients, because so many reasons the volume of distribution increased in these patients. If you see the open circles, this is the volume of distribution of the healthy patient. This is the open circle line, and the filled circle is the like increased volume of distribution. If you see the filled circle in the ICU patients of the different antibiotics, meropenem, imipenem. If you see any beta lactam antibiotic compared to the healthy volunteers, the volume of distribution is increasing drastically. And yeah, so if you see the antibiotic wise, aminoglycosides, what happens if the increased volume of distribution with the fluid shifts, the patient receiving fluid resuscitation, the patient on inotropes. So what happened with the increase the volume of distribution of the fluid shifts? They can very sensitive the fluid shifts, and decrease the Cmax because they can distribute into the from central compartment to other compartments, and altered clearance in the critical patient. Yes, they stay in the extracellular fluid only. And cephalosporins, the same, they can influence by the increase the volume of distribution of the fluid ships and decrease the Cmax, and but they stay in the extracellular fluid. And the carbapenems, volume of distribution 20 to 40 liter, and they can influence by that with the fluid shifts, and Cmax also influenced, and but they stayed in the extracellular fluid. But glycopeptides, they can also influence by the fluid shifts and decrease the Cmax, but varies proportionally with the renal function. Increased ecoplasmin clearance in the, we can see the hypoalbuminemia patient. But the tigecycline is unlikely affected by the fluid shifts, and tigecycline Cmax unlikely affected by the fluid shifts. So because our first four antibiotics are the hydrophilic antibiotics, and the tigecycline, clenda, and linezolid, they're basically these are lipophilic antibiotics, and linezolid is like amphoteric, like it's a hydrophilic and lipophilic. That's why it can affected by the both changes. But the linezolid have excellent good volume of distribution. It doesn't stay in the ECF. It can distribute in the total body water. And TG and Clinda not affected by the any of the fluid shifts. They have a good volume of distribution. They can distribute in the tissues. And colistin likely, but not S. So it have a like good volume of distribution. And fluoroquinolones, volume of distribution not influenced by the fluid shifts, and but the Cmax is the change by the fluid shifts. So they have a good volume of distribution, the similar like a volume of distribution, vancomycin. And so this is the background of all the antibiotics that affected by the fluid shifts. And so we learn like we know that volume of distribution is influenced by the different regions. So it can lead to the suboptimal drug levels. So that's why the guidelines recommending the loading doses. So how loading dose helps? Loading dose helps to achieve the initial therapeutic level, I mean Cmax, quickly before the steady state. So we don't want to wait to steady state achieve, because it will take to 4 to 5 half-lives. It depends on the particular T of the particular beta lactams. Beta lactams say 1 hour. Some drugs have like 7 to 8 hours. If it is like 4 to 5, it will take to around to 24 to 48 hours. But that is not ideally good option for the septic patients. So we have to reach the Cmax as soon as possible. The Cmax value always almost equal should be to the CSS. So if you give the loading doses, that can help us to achieve the CSS level with the Cmax. And without loading doses or delayed loading doses or longer infusions of the loading doses can change the pathogen susceptibility. So ideally, your loading dose should be like it should be more than your regular doses, and it should be like a very fast compared to the regular infusions. And if you delay in that loading dose infusion, it can change the pathogen susceptibility. So optimal loading doses minimize and prevent the application of the resistant mechanisms like efflux expansion and foreign expressions. If you see the one example in the fluoroquinolones, the first dose resistant mechanism activated very fast with the suboptimal dosings, with the only single dose. So efflux pump upregulation occurs within the 2 to 4 hours. If your fluoroquinolone dose, like it is very inappropriate in the like levofloxacin, if you give like 250, 500, like that, like, so this is a very, very suboptimal dose in the sick patients. So the suboptimal doses can lead to activate the efflux pump upregulation within 2 to 4 hours, and rapid induction of PAD B, and ABC transporter proteins. Basically, they can induce that these proteins within 6 hours. So always first dose should be optimal, and that should be high. Otherwise, like underdosing can cause increase the resistance. So to minimize the amplification of the resistant strains, the PKPD target should be ideally be achieved by the first dose, not several doses later. So that's why we always focusing on the first dose, that is the loading dose, that should be like appropriate, not suboptimal. So how loading doses works? If you see this graph, if I give the loading doses, I can achieve the Cmax like within hours, If I don't give loading doses, you can see the small frequent doses of or continuous infusion of given without loading dose. You can see the gap. You can achieve the loading dose like several hours or several days later. And if you use the loading dose, you can achieve the loading dose Cmax very fast. So that is the important of the loading doses. And so there are like basic different various pharmacokinetic equations can use to calculate that loading doses. So these are the basic formulas I can apply in my practice to calculate that loading dose when I have required loading dose and maintenance dose. For loading dose, you require volume of distribution and the target concentration and the bioavailability. If you give the IV route and the bioavailability always 1, like 100%, the fraction of bioavailability always 1. And the target concentration, it should be depend on the particular antibiotic. So the target concentration and volume of distribution will depends on the patient comorbid conditions. It will change for different for the different populations. So the required which patient which volume of distribution will get it from the literature, and the target concentration usually will also get it from the literature. So if you have these two volumes, you will get it from the different resources. If you apply these formulas here, maybe you can get the loading doses value. And you can apply the similar formula for the maintenance dose we'll be discussing in further. Yeah. So if you don't have like volume of distribution and the target concentration, but you can find the half-life from the any literature FDA label or the different drug doses. You have the half-life of it's commonly available in the any literature. So just you can apply the maintenance dose and half-life formula, and the 0.7 is the dosing interval. Like what is the regular dosing interval, like whether 8 hours or 12 hours. Half-life how much it is, like 1 hour, 2 hour, like 3 hours or 4 hours. And the maintenance dose. Just you can apply this formula, you will get the loading dose. This is the one of the simplest way to calculate the loading dose, where you don't have like volume of distribution and the target concentration. If you don't know the volume of distribution of that antibiotic, you don't know the target concentration antibiotic, then you can apply this formula to calculate that loading doses. So this is one of the simplest formula. And so ideally, loading doses, loading doses decrease the time to achieve the target concentration, because if you give the loading dose, higher loading doses very fast, it can uh, help us to decrease the time to achieve the target concentration. Ideally, maybe days to hours. And basically, it is required in the septic shock patients or patients with nephrotic syndrome. See here, if you give loading doses as well as the maintenance dose with the red color one, so you are achieving the faster load Cmax values and the faster CSS concentration compared with the only maintenance dose. If you see this graph, you can observe. So when the plasma TF is prolonged, especially in the CK deviations or AK patient or any organ dysfunction patient, time to reach the steady state concentration or the target concentration is increased proportionately. So we can, to overcome this, we are giving the loading doses. An increase in the drug TF prolong the time to achieve the steady state plasma concentration with the maintenance dosing. So administration of loading doses reduce the time to achieve the therapeutic plasma concentration. Yeah. So if you see this formula, half-life formula, 0.7 in the volume of distribution of the clearance. So if I double the volume of distribution and if I make it half of the clearance, then there is no change in the half-life. But they have if you see, if I double the volume of distribution and if I maintain the half of the clearance value, but there is no effect, because if you apply multiply with the 2 and it is a 1/2, then half-life is the same. There is no change in the half-life, but they have a different concentration profile. But especially we can see this particular pattern of plasma concentration, the time profile in the beta-lactam antibiotics. And if you see the AUC based practices and the dose by clearance AUC formula, if I make it half of the clearance and if it is half, means it automatically increase the AUC to double. So compared to the normal kinetics, like fluoroquinolones. So the fluoroquinolones half-life is decreased from the normal, then the AUC automatically going to the 2 times. So this type of pattern we can see in the fluoroquinolones. If you if you have the clearance, like the clearance is like 10 hours, and if you have the clearance to 5 hours, like clearance is decreased to 5 hours, then the AUC become double. And if you see this kind of practices, Cmax is called dose into fraction of bioavailability by the volume of distribution. If you double the volume of distribution and lead to the reduction in the maximum plasma concentration, but no change in the area under the curve. Yeah. If you doubling the volume of distribution, that means Cmax become a 1 by 2. Just you can apply this formula, you understand. So Cmax become a half and the volume of distribution become a double. So this kind of pattern we can see in the aminoglycosides. Yeah. So coming to the beta lactams, ideal ICU target recommended by the different societies. For 100% dosing interval, your drug concentration should maintain 4 to 8 times of the MIC above the 100% dosing interval. So that is the initial target. And the subsequent target, C minimum by MIC, that should be like 4 to 6. This is the subsequent target. If I see that clinical breakpoints of enterobacterials and the Pseudomonas, susceptibility 1 for enterobacterials, resistant for the 4, and the Pseudomonas 2, and the resistant for the 8. So if I apply this into in a table for 100% dosing interval FT T by MIC, for enterobacterials the required target is the 4 to 32, Pseudomonas is the 8 to 64. So if I calculate the Cmax for from the literature for these two organisms, the required Cmax is the 118 plus or minus 25. And so if I give the IV bolus, I can achieve the 118. So the actual required target is 4 to 32, but we are achieving with the 118 for enterobacterials. For Pseudomonas, we required 8 to 64 target, but if I give antibiotic IV bolus, I'm achieving 118. So I'm achieving more than the required target, almost on the double in a very faster time. But if I give first dose of antibiotic, like 3-hour infusion, like 1 gram meropenem 1 gram, 3-hour infusion, and meropenem 500 mg 3-hour infusion, my Cmax is almost all 1 by third compared to the IV bolus. Like I'm achieving only 24, around 25, and with 1 gram, 1 gram and 500 mg with 3 grams. If you see these 2 points, like the dose of loading dose, the quantity of the loading dose also very important, and the infusion time also very important. If you do the longer infusions, then you cannot achieve the Cmax. You are achieving the Cmax, very low Cmax, and that should be below the required target. Just you can forget about the 4 and 8. See, the required target for Enterobacteriaceae or E. coli, the required maximum target is the 32, but with the 1 gram of 3 hours bolus infusion, I'm achieving only 24. So we are achieving the required target is 32, but we are achieving the less target. So this is a very important. So you have to give the first dose of antibiotic as well like IV push. Don't give the IV infusion. So but IV bolus makes the first dose that means you have to give the first dose very faster infusion like 5 to 10 minutes, not like 3-hour infusions. So that can help you to achieve the Cmax, the required Cmax as soon as possible. So that is a take home message from this slide. Yeah. And even with if you give the bolus injection, you have a good half-life, you have a longer half-life compared to the 1 gram and 500 mg of bolus of meropenem. And if you maintain the proper, if you have a good volume of distribution, this can help you to the IV bolus can help you to distribute the meropenem in the different body parts from the central compartment, the different body parts, because the volume of distribution is very good compared to that infusions like 3-hour infusion, 500 infusion for the first dose. Next. So just some scenarios of the loading doses. Longer loading doses can cause therapeutic failure. As we see, if you give the longer loading doses, like longer infusion, like 3-hour or 1-hour infusions of 2-hour infusions of antibiotic, of beta-lactam antibiotic, we cannot achieve the Cmax. It can lead to the therapeutic failure and the resistant development. So IV bolus of the loading doses help to achieve the Cmax, early Cmax. You see already we do the 500 mg, 1 gram of meropenem we give in 5 to 10 minutes. We achieve the higher Cmax that is required more than the required target. So because beta-lactam have a short half-life and they have a low volume of distribution, and ideally you can give 5 to 10 minutes, but sometimes our institute will try to give it in 15 to 30 minutes, some other reasons. The example like beta-lactam antibiotics. And there is a second scenario, you cannot give the faster IV bolus. In the beta-lactam section, you can give the bolus is a very fast, but there are some scenarios you cannot give the IV bolus. Some particular antibiotic like azole, secanocanins, polymyxins. These antibiotics you have to give like slower infusion. First dose should be, loading dose should be like a slower infusion, like 1 to 2 hours. you cannot give like 5 to 10 minutes because they have a longer half-life and the high volume of distribution. They have a redistribution phenomena into the different body parts. They can cause trigger the toxicity. So scenario one is the different from the scenario two. In the scenario one, we are giving the beta-lactam antibiotics. They have a short half-life and the low volume of distribution. The first dose always should be the a very fast infusion like IV bolus 5 to 10 minutes. In the scenario two, antibiotics have a long half-life and high volume of distribution like echinocandins, polymyxinazoles. They have to give first dose. You have to give first dose, but it's like an infusion, 1 to 2 hour infusion, not like a 5 to 10 minutes infusion like that. So that is a two different scenario of antibiotic loading doses infusion practices. So what are the recommendations from the Society of Critical Care? So they are also recommending the loading dose like different beta-lactam antibiotics, epinephrine 2 grams, meropenem 0.5 to 1 gram, and the 0.5 to 1 gram depends on the like different clinical scenarios. That depends on the severity of the septic shock. How many inotrope patient are like patient have a fluid overload, like the patient have AKI and patient on mechanical ventilation, these things, and patient prior have any like gram-negative infection, and we have any evidence for the current gram-negative infection. All these things might influence, and loading dose formula you can apply. That depends on the target concentration, the volume of distribution, and the loading doses value may be changed. For some patient, maybe it is 500. Some patient maybe go up to 2 grams also, not always 1 gram. And Piptas 4.5, but now like the recent Italian French guidelines recommending 9 grams for Piptas. When you are hitting with higher MSC target organisms, patient already have E. coli, ESBLI. So now you are treating as empirically. So then your loading dose should be ideally like 9 grams, not 4.5 grams. Then you can, next dose should be like 4.5 grams over 4 hours infusion, like that. And ceftazidime 2 grams, and napsilin 2 grams. So here also see loading dose should be infused over 30 minutes. So ideally it should be like 5 to 10 minutes, but there are some reasons they are mentioning the 30 minutes. Yeah. So after giving the loading dose, so when to give the next loading doses? So there is always confusion to the nursings also, like we're getting so many calls every day. I give the loading dose. When should I give? So give loading dose now meropenem at 9 a.m. So usually 1 gram TID of merogram. So generally before we implementing this practice in our hospital, they'll give the 2 gram of loading dose now. Then they wait for another 8 hours to give the next dose of antibiotic. So basically that is wrong practice. So because beta lactams have a short half-life, if you wait for the 8 hours, almost all like your beta lactams 1 hour half-life, maybe if you took like 4 to 5 half-lives to steady state, maybe in next 5 hours, 50% of the meropenem drug levels is excreted from the body. So there is no point of waiting 8 hours to give the next dose after giving the loading dose. If you give in case of intermittent infusion, like the patient is not in septic shock, this patient not require any loading doses. It's like a standard dosing protocol. You have to give first dose and next dose should be like 8 hours gap. If in case it is a TD dosing, if it is a BD dosing, then your next dose should be like after 12 hours. If it is TD dosing, your next dose should be like after 8 hours. But if in case of prolonged infusion, like ICU patient and septic shock patients, start the next dose at the time of the half of the dosing interval. Suppose meropenem dosing interval is the 8 hours. So loading dose you give now loading dose, then you can give the next dose after 4 to 6 hours, not after 8 hours. Because to maintain the minimum drug level, you have to give the next dose as soon as possible, at least minimum half of the dosing interval. If you give the loading dose now, next dose not should be not after 8 hours, next dose should be after 4 to 6 hours if you practice the prolonged infusion. If in case continuous infusion, if you give the loading dose now, you have to start the next dose, second dose of antibiotic. Like ideally, it is like maintenance dose of antibiotic immediately after the end of the loading dose infusion, because the continuous infusion of antibiotics makes the like very minimal level of concentration of antibiotics, so they don't achieve. Sometimes they are not during the like infusion time, they don't cross the MSC of the antibiotic. Maybe that may be trigger the resistant pathogens. So that's why after giving the loading dose, immediately you have to start the antibiotic in the continuous infusion, because the continuous infusion deliver the standard amount of antibiotic into the systemic circulation. So there is no C minimum, C max, or C max and C minimum. I mean, there is no ups and peaks and downs. So you have a like constant delivery of the drug into the systemic circulation. You cannot expect up and downs in the continuous infusion. That's why you have to start the second dose of antibiotic immediately after the end of the loading dose infusion. But in the prolonged infusion, we are giving antibiotic every 4 hours. There is, you can expect a little bit up and downs. So you can give half of the dosing interval. In the standard infusion, we are giving antibiotics 30 minutes, 1 hour. So this 30 minutes to 1 hour makes to the reach the drug level to Cmax like more than like 4 to 5 times of the MICs. So that level should maintain around like 7 to 8 hours. So you are giving anyways next 8 hours. So there is no much drug level, I mean Cmax level, C minimum level difference in the systemic circulation. So there is no problem with the intermittent infusion. The problem is the only the prolonged infusion and the continuous infusion. Yeah. So there are some particular antimicrobials with the more than one loading dose. So you have to know when you are in a rounds whether your clinician mentioned number of loading doses properly or not. Posaconazole, voriconazole, 2 loading doses, but the timeline should be within 24 hours. You have to calculate very effectively. If they start today 9 a.m., they have to finish tomorrow at 9 a.m. They have to finish the 2 doses at any cost. So it's like some kind of medication error. Sometimes some nurses, sometimes they miss and due to shift changing and so many reasons. So, but we have to be very careful when you're doing audit whether they give the antibiotics as per the limit uh, recommended timeline or not. Isavuconazole 6 doses in the first 2 doses, and itraconazole 9 doses within the first 3 days. Bedoquilidin 14 doses in the first 14 days, and the ticoplanin in first 3 days. Now we are giving the ticoplanin like 6 doses up to like depends on the clinical situation, but they have to go within the timeline. So if they don't give within the timeline, there is no point of giving the loading dose. This is the timeline is a very important to achieve the steady state concentration and early. As soon as possible. And the ticoplanin not require any dose adjustment up to 4th day, regardless of the creatinine clearance. Any antibiotic, this is the antibiotic. Sometimes they feel that patient have AKI, so they give the first dose perfectly, like voriconazole 200 and they are cortisone 300, they'll give. What they do next dose patient have AKI, they'll adjust the dose. No, loading dose is not mean for the adjustment of doses. We are going to discuss in detail. So we have to count the how many doses is prescribed, how many loading doses are prescribed to the patient, how many loading doses given to the patient, regardless of organ dysfunction. And so we already see the loading dose formula. The loading dose always depends. The loading dose it means for the distribution, not for the excretion, not for the clearance. And the loading dose is directly proportional to the volume of distribution, the targeted concentration. So there is no point of adjusting the loading dose in any kind of organ dysfunction. But there are certain exceptions. And if you give loading doses AK and CKD, give the full dose, and you can apply that loading dose calculation formula. And in CRRT also you have to start with the full low dose. We have a CRRT loading dose formula, same formula, just you can apply the target concentration, the volume of distribution by the bioavailability. And because the constant extracorporeal drug removal, that makes like, so you have to give the loading dose, that is the reason. And obesity also start with the full loading doses, but you can use the total body weight for the vancomycin and daptomycin, and adjusted body weight for the aminoglycosides because of their toxicity and their hydrophilic and lipophilic nature. And which patient you give the loading doses. So generally we have a guide, Society of Critical Care recommendation for only septic shock, but there are like it's not a like standard recommendation, but there are so many review articles from the expert opinion I gathered here. Any patient come under these clinical conditions, we'll recommend the loading doses on this particular patient. And the patient diagnosed any MDR infection, you can start regardless of septic shock. You can give the loading doses. Any deep-seated infection, any stable patient, but you can hit with the loading doses and go the next maintained doses. Meningitis and febrile neutropenia, always febrile neutropenia, start with the loading doses. Cystic fibrosis and hypoalbuminemia, any organ dysfunction, CHF, CRRT, ECMOS, start with the loading doses. Obesity, burns injury, pregnancy, and patient around major surgeries. So these are the patient different clinical condition ideal for the starting the loading doses. Not only always sepsis and septic shock. And something about the some of the antibiotics. I'll took some examples. Colistin bacterial killing rate and timeline. Bacterial amount target. It should be like minimum less than the 3 log unit of the CFU. Then it could be very effective. So if I give like 240 mg, 3 million of the colistin methane sulfate, it will take to 20 hours to achieve this less than 3 log unit of the CFU. So 20 hours is a very long time in a sick patient. If I give the 480 mg of the colistin, then it will take to 11 to 12 hours to reach the 3 log units. And if I give that 9 million units dosing, then I can achieve this uh, level, this range within 5 to 6 hours. So this is the importance of the loading dose as well as the quantity of the loading dose also influence the microbiological target uh, outcomes. So your loading dose should be should be quantified, like it should be like ideally should be like compared to minor should be like very high, and it should be given a proper administration time. So higher doses help to rapid bacterial kill, likely mean a faster resolution of the infection in the seriously ill patient. If you clear that bacteria from that systemic circulation, automatically it can help you to the come out the patient from the sepsis. And the colistin loading dose in critical ill patient with the low albumin levels. So basically the 9 million units we are giving every patient loading dose of the colistin in every sepsis patient. But scenario is very different if the patient have a hypoalbuminemia. So albumin levels altered in sepsis patient will commonly see in sepsis patient. At low albumin level, colistin follows nonlinear binding. If the patient have a normal albumin, that's okay. That follows the linear binding. But if the patient have hypoalbuminemia, the patient is low albumin levels, colistin follows the nonlinear binding. Though we cannot predict that free colistin levels are unpredictable. So maybe antibacterial efficacy is compromised. Either maybe colistin levels very high or it may be very low because it follows the nonlinear binding. Either you can expect the very high level or you can expect the low level, you can expect the maximum normal level also. So we don't know like whether it how colistin is behaving because it follows the nonlinear kinetics. So lower doses have the lower free drug levels will compromise the bacterial killing. So we have to give higher loading doses. If you give maintain the higher loading doses, it can follows the linear protein binding compared to that lower doses, because lower doses for the linear binding kinetics. Higher doses follows that linear protein binding kinetics. These can increase the free drug levels and maximum bacterial killing. So don't use the lower doses of the colistin in patient with the hypoalbuminemia because it can lead to that non-linear kinetics. It can we can lead to the unpredictable colistin levels, and always use the higher loading doses because linear protein binding increase the free drug levels and it can enhance the bacterial killing. So if you see this graph, if I don't give the loading doses, without loading doses, 2-3 days will took uh, to reach the steady state concentration. Like if I give the 3 million units TID without loading doses, it will take 2-3 days. If I give 4.5 BD dosing, it can achieve the faster Cmax CSS level compared to the 3 million TID. If I give 9 million units and 2 minute loading doses, it can achieve the same average CSS concentration, but 15 to 2 hours infusion, same levels, but lower Cmax of the CMS within 2 hours. So here, like loading dose is very important with the higher loading doses. So if you don't give the loading doses, you cannot achieve the CSS level as soon as possible. Yeah. We all know the colistin is a like nephrotoxic medication. So, but can we give loading dose in colistin if the patient come with the CKD and AKA? Higher Cmax concern about the nephrotoxicity, but mean Cmax 2.93 mg per liter. 15 minutes after end of the 30 minutes infusion in regular patients, the CMS Cmax can be lowered by the increasing infusion time of the loading dose. See, if you give faster infusion, maybe that can hit with the maximum Cmax of the colistin. That is the one of the this is the target for the nephrotoxic. If you cross this 2.93, maybe you can expect the early nephrotoxin in the colistin received patient. Because if you give the faster infusion, so if in case if you increase the infusion time, like it can make 2 hour infusion, maybe it can delay the achieving the Cmax, but it does not compromise the bacterial killing rate. So ideally, you have a patient with a cholesterol, you have a patient with a CKD AKI, if you want to give the loading dose, don't give in 15 minutes, try to give in the infusion, like 1 to 2 hours infusion. So that can help you to achieve the Cmax, and as well as it doesn't cause any AKI, or it doesn't cause any nephrotoxicity, yellow nephrotoxicity, and it can actually help you to the bacterial killing. So loading dose in AKI, CKI patient of cholesterol, infusion is loading dose is the 9 millimeters, but don't give in 15 minutes, give in 2 hours infusion. Yeah, same like vancomycin loading dose in critical ill patient with the low albumin levels. If you give the loading dose of vancomycin in hypoalbuminemia patient, it can achieve the higher trough, like almost 34.5 mg per liter, regardless of the baseline renal function. Either you have an normal renal function or abnormal renal function, that trough level is very high. We already know the trough levels of vancomycin associated with the nephrotoxicity. So hypoalbuminemia patient with a older than 75 significantly prolong the vancomycin elimination time, increase the AAC by MIC more than 450 mg per hour ml. So higher trough, C minimum more than 15 mg per liter, higher MAC significantly increase the risk of nephrotoxicity. This already we know. So be cautious of the loading dose in a hypovolemia patient. So this is the only one of the exception for the loading doses. Apart from that, other antibiotics. If the patient have a hypoalbuminemia, you are giving loading doses, you should care about and cautious about the nephrotoxicity of the in that particular patient. Otherwise, if the patient have no normal albumin levels, you don't have any, no need to worry about loading dose of the vancomycin. You can give the full loading dose, 25 to 30 mg per kg. But if the patient have given you the full doses, but you should be cautious about that nephrotoxicity, because that we can achieve the higher trough levels with the loading doses. See the graph. The patient who have albumin levels less than 25, if you give the loading doses, you can achieve the higher C minimum. It can associate with the nephrotoxicity. Yeah. So coming to the maintenance dose. Next is the maintenance dose. This is the dose of producing the steady state plasma concentration and equivalent to the amount of the drug estimated since last administration. So after 4 to 5 half-lives of the drug, then it can start getting excreted from the body. Yeah. Maintenance dose depends on the clearance of the elimination. So because maintenance dose directly proportional to the clearance, so maybe required dose adjustment in the organ dysfunction like hepatic dysfunction in the renal dysfunction. So maintenance dose strategies for the AKI patient. AKI we can see commonly seen as sepsis patient. These patient rapidly changing serum creatinine. Whatever the equations available currently, CKD equation or Quadcott formula and MDRP equation, something different equations. Whatever equations, these are very inaccurate and inappropriate, and no guidance is recommending using these equations. Currently, we don't have any standard recommendations how to dose in dosing in AKI patient. There are multiple factors involved in the dosing of the AKI patient, and if the patient is sepsis, maybe like some of the author recommending you can delay the antibiotic dosing up to 48 hours because of the hyperdynamic sepsis and because of achieving the good MAC, good target of Cmax levels. But currently there is no recommendation for the KIDCO and there is no recommendation for the FDA how to dose AKI patient. But there are still some Jellyfy CKD EPA equation is there. Sometimes that is validated in some small set of patients, but usually compared to that Corker formula and CKD equation, Jellyfy equation is a very good equation for patients with unstable creatinine clearance. Sometimes we are utilizing in our ICUs to dose AKI patient by using that particular equation. Yeah. So coming to the maintenance dose strategies for CKD patient. Yeah. So how to give the maintenance dose in a CKD patient with a renal dysfunction. So initial estimation of drug clearance, elimination rate constant. Either you can find the drug clearance and elimination rate constant, these from the PKPD literature data. Either go to the any PKPD textbook, or you can found it from the like any infectious review articles literature. You will found the value of creatinine clearance or rate constant. Either you can visit my FEA basic module cycle 1 PKPD presentation. There I mentioned about how to calculate that renal elimination rate constant as well as total clearance. There I mentioned the different equations to calculate these two parameters. You can get it from those presentation also. And if you have the drug clearance as well as the elimination rate constant, then the next step we need is the calculate the dose adjustment factor, that is called the Q. We can calculate the dose adjustment factor by using the two formulas. Uh, One is K value from the reduced renal function and the K value from the normal renal function. This is the elimination rate constant. And then another formula is normal renal clearance as well as the renal dysfunction, reduced renal function clearance. So by using these formulas, we can calculate the dose adjustment factor. If you don't have K value and the clearance value, we can use this formula. Q is equal to 1 minus Fe into 1 minus Kf. Basically, Fe is the fraction of drug eliminated unchanged renal in subject with the normal renal function. So this value will get it from that literature of the every antibiotic have a different fraction of drug eliminated unchanged. They have a different antibiotics. They mention the literature. Every antibiotic have a different value, 0.97, 0.85. So you have to use these formulas in this value. And Kf is the ratio of the patient creatinine clearance. I mean, if the patient have AKR CKD, first you have to calculate the patient creatinine clearance, then divide it with the normal clearance. Suppose you have calculated the patient creatinine clearance around 60 65, then your Kf is 60 by 120. That means 0.5. Your KFL is the 0.5. Then this Fe value will find it from the literature. That may be 0.97, 0.75. Then you can apply that 0.9 into 1 minus Kf into 60. Then you will get the dose adjustment factor. So this is the step 2 for the dose adjustment factor. This value we can use in the next steps. Yeah. So the calculation of the new dosing interval or new dose. So new dosing interval is equal to by the normal dosing interval by the dose adjustment factor. We already have the dose adjustment factor from the step 2, and we already know the normal dosing interval. Whether you regularly you are giving TID dosing for meropenem TID, I mean 8th hourly dosing, or piptaz 8th hourly dosing, amikacin OD dosing, levofloxacin OD dosing, that means 24-hour dosing. So that this is the normal dosing interval, and that dose adjustment factor will get it from the step 2. And this is for the dosing interval calculation. Same like the new dose calculation. What is the normal dose? What is the normal dose for like meropenem 1 gram, levofloxacin 750, amikacin 1 gram, like that, ciprofloxacin 400 TID. So you have to substitute with the particular antibiotic normal dose, colistin 9 millionents. By the dose adjustment factor, whatever you got from that second step 2, you can apply this formula. You will get that new dosing interval or new dose. Okay. And other than, you can use this formula also to calculate that new dose. If you don't have these values, you can use this formula to get that. This is another alternative formula to calculate the new dose or new dosing interval. So these methods are really helpful for like especially Indian settings where we don't have a TDM is not available for every antibiotic. So by using these simplest equations, we can calculate that required dosing interval as well as the required dose. Sometimes we use these formulas to calculate our patient. So these approaches, basically these formulas derived from the PKPD studies, especially patient with the renal impairment. And these equations serve as the basis for the making the initial decisions based on renal function. So we have a good literature of most of the antibiotics, whatever the available antibiotics, all the beta-lactams, aminoglycoside, fluoroquinolones. We have a good literature and studies on the renal dysfunction patient. So you will get it the whatever the value from the literature. You can apply these values like Fe value and Kf value and drug clearance value and rate constant from the literature, and you can calculate the dose for your patient. Yeah. So maintenance dose strategies for the patient receiving the hemodialysis. The first one, AKA patient. The second one is CKD patient without hemodialysis. And the third one is patient receiving the hemodialysis. The CKD and MHD, basically the dialysis dependent patient, like who underwent the dialysis every 48 72 hours. Basically they have a very residual urine output, like less than 10 ml, less than 15 ml. Not ideal for AK patient and HD patient. So whatever the dosing, we have a standard dosing for the CKD MHD patient, but sometimes our the patient admitted in ICU patient, sometimes they also underwent 4 hours of hemodialysis. But unfortunately, we are using the same dosing practices where we are using for the MHD patient, but these are not ideally for the AKI patient who are undergoing the hemodialysis. So the dosing practices are very different. Those dosing practices mean for the only CKD patient, not for the AKI patient, because CKD dosing, the creatinine, they already have the baseline creatinine, the studies whatever they done in especially in the CKD with MHD patient. These the equations and these formulas and the literature not applicable to the AKI patient and HD patients. So, and that is one thing, and the SD prescription pattern changes in the over the years, because we are using the advanced dialysis flow rates, and we are using the flow rates, different flow rates, and we are using the high influx, higher flux, larger surface area dialyzers, and then different new dialysis filters. So whatever the studies published on the dialysis dosing in CKD patient, almost all that is around 1995, before 1995, they are using the dialysis machines or dialysis membranes, low efflux membranes, and they did the studies and they derived these dosing equations, and they come up with the dosing recommendations. But now we are using the different filters and different membranes. So whatever the dosing published in the earlier literature, currently those are not currently applicable for our patient. So these, and after 1995, currently in the market we have like under dialysis filters currently available. So every dialysis filter have unique to they have a unique property, and they have a unique clearance of the antibiotic. Sometimes the newly filtered antibiotics, they clear the antibiotic the molecular weight less than 1000, also less than 5000 also. Generally we studying the dialysis principles, if the antibiotic molecular weight more than 5000, more than 1000, that generally not eliminated by the HD dialysis filter or something, dialysis membrane. But maybe that is wrong, because the current whatever that like advanced filters or advanced dialysis membranes, they are able to remove that small molecules like beta lactam molecules. They have molecular weight less than 5000, less than 1000 also, they are able to removing the beta lactam antibiotic also. So whatever the dosings derived in the previous literature, they are not applicable for now, because we have advanced dialysis settings and dialysis practices. So in addition to the dialysis machines, they are able to significantly removing the beta lactams, other antibiotics around 50 to 100% noted for the many antibiotics, especially antibiotics molecular weight less than 1000. So when you are using the old dialysis recommendation to your patient, please keep these things in your mind. Yeah. So whatever the dosing we are giving, most of the time we are giving the antibiotics after the dialysis, especially in some cases for aminoglycosides, maybe we try to give before the pre-dialysis, I mean before the start of the dialysis, because we maintain that trough level, we maintain that Cmax and C minimum level to maintain the maximum Cmax and to prevent the toxicity. That's why we're giving that aminoglycoside before the dialysis. But apart from the regular beta lactams, we are giving post dialysis, because of the most of the beta lactam molecular weight less than 1000, less than 500, 5000 Daltons. Most of the like newer dialysis membrane filters removing the beta lactam effectively to the dialysis machine. So that's why we're recommending after dialysis. So if I have a patient, how to calculate the dialysis dose? If you don't want to depend on the older literature, if you want to calculate the dialysis dose to your patient, how to calculate? So these are the two formulas sometimes we are using our patient. So for that, you need these particular values to calculate post dialysis dosing. You can use the patient estimated volume of distribution of the that particular drug. So you need to find what is the volume of distribution in CKD HD patient of the particular antibiotic. This you will get it from the this value you will get it from the literature, and e power of kt. So this is the fraction of the drug concentration remaining at the end of the dialysis. So you did the dialysis. After completing the dialysis, what is the fraction of concentration drug available in after the dialysis completion? So this EKT value also will get it from the literature, and EKHDDT. So this is the fraction of drug concentration remaining as a result of the elimination by the dialyzer. So this EKHD value also will get it from the literature, and this is the patient residual total body clearance, and the elimination by the dialyzer. the KPT and KHD values you have to calculate. You have to know the patient total clearance and the volume of distribution to calculate the patient residual total body clearance. And elimination by the dialyzer, you have to know the clearance of the particular antibiotic by the dialysis machine and by the volume of distribution in the HD patient. If you able to capture these details of the parameters, then you can apply this formula to calculate the post HD dosing of your patient. If you don't depend on the like older dosing practices. Yeah, that we finish the post dosing calculations. Then we are coming to the CRRT dosing. So then we have a two types commonly using CRRT two types, CVH, continuous venous filtration. We are using convection and the ultrafiltration, and CVHDF, convection and the ultrafiltration, the diffusion. These are the principles we are using in this CRRT procedure. And how to calculate. If you want more about the CRRT dosing, just last year Dr. Grace presented in last year ID Congress and how to dose antibiotics in the CRRT. Just you can visit that PPT or you can visit the talk. And so I'm talking about the PKPD point of view. I'm talking about that practical point of view, how to calculate the dose in CRRT patient. So when you give a drug, either it can maybe we have the two major elimination organisms. Either it may be liver, either it may be kidney, maybe some other miscellaneous elimination of the particular and drugs. So majority of the times for hydrophilic drugs, kidney, lipophilic drugs is the liver. So when you calculating that clearance, you need to be thorough about in a dialysis. I mean, when you're doing that CRRT, you need to be know residual clearance of the particular antibiotic after dialysis, completing the CRRT. And some patients have some creatinine clearance, some patients have some urine output, so that is called the residual clearance. And some antibiotics are excreted to that residual amount of urine also, so that's why you need to calculate the residual creatinine clearance. And you need to calculate that how much of the amount of the antibiotic cleared by this CRRT procedure. So then you have to combine. So this is called the total drug clearance while patient on the CRRT. So for that you need the residual antibiotic clearance as well as the CRRT clearance. If you combine these two, then you will get the total. So this is the step one. Step two, you can calculate the dose adjustment factor. The same thing we can see in the dosing in CKD patient. The same formulas we can use to calculate the dose adjustment factor, and we can apply this formula. And same formula, and the step three, we can use the same formulas for the dosing interval or new dosing calculation for the same formulas. The step two and the step three is the same. You can apply this whatever the CKD, what we discussed in the CKD section. You can use the same dose adjustment factor formulas. You can use the same dosing interval and dosing interval formulas to calculate new dose and the new dosing interval. So we are going to see the next slide. Yeah. I gave one example here. The patient with the creatinine clearance 10 ml per minute is on the CRRT like CVHDF with using some ANI filter of the blood. So you have to know which type of filter we are using, because the different filters have a different blood flow rate, and they have a different alpha filter rate, and they have a different dialysis flow rate. If you don't know anyone using CRRT machine, CRRT in our hospital, there is a display to the patient bedside near the CRRT machine. There they're displaying the blood flow rate, alpha filter rate, and dialysis flow rate. If you're not able to get it from that literature, you can use those values, the blood flow rate, ultra filter rate, and dialysis flow rate. So for this patient, blood flow rate is the 200 ml per minute, ultra filter rate is the 12 ml per minute, dialysis flow rate is the 33 ml per minute. So these three values we need to calculate, we require to calculate the CRRT dosing. Okay, apart from that, clearance 10 ml per minute. So first we need to calculate the residual creatinine clearance. The patient creatinine clearance is the 10 ml per minute. So this is the standard equation for the septagelim. This is we extracted from the PKPD equations. every antibiotic standard clearance equation, you'll get it from the PKPD literatures. For Cepifime, 0.96 into 10 in the creatine clearance is the 10 year. So you have to multiply with the 10 plus 10.8. Then the residual creatine clearance is the 20.5 ml per minute per Cepifime. So this is the residual clearance, residual creatine clearance of the Cepifime excreted by the kidney after the CRRT. And you have to calculate the now second step is the Cepifime clearance associated with the CRRT. So CRRT clearance, then you have to use this formula. You need ultra filtration rate plus dialysis filtration rate into fraction of unbound value. Fraction of unbound value of the particular antibiotic. This you will get it from the literature. So we have ultra filter rate 12 ml per minute, already we mentioned, and the dialysis flow rate 33 ml per minute. Fraction of unbound value is the 0.97. Just you can apply these values in this formula. 12 plus 33 plus into 0.97, that is 43.7 ml per minute. So then you have a value of Cepifime clearance during the CRRT, and you have a value of Cepifime clearance during the residual clearance value. So you need to combine this 20.5 and 43.7, you will get the total clearance. Yeah. So if you combine the total clearance formula, you need to combine the residual creatine clearance as well as the CRRT clearance. The residual creatine clearance value is the 20.5, CRRT clearance value 43.7. Then if you combine, we'll get the total clearance value, that is a 64.2. Then we can apply the dose adjustment factor formulas. We have the dose adjustment factor formulas. Then we have the total clearance, that is 64.2. Normal is 126. Normal creatine clearance is 126 of the Cepifime. Okay. Yeah. Then the dose adjustment factor is the 0.51. So we have the step 1 and step 2, and now we are going to the step 3. So for this patient, initially he has an normal regimen of Cepifime 2 grams every 12 hours. This is the normal dosing for this patient. So if you want to maintain that normal dose, you want to give the only 2 grams only, then the extended dosing interval, you want to give the same dose, but you want to calculate the dosing interval. So this is the formula for dosing interval. Dosing interval for this renal dysfunction patient, dosing interval, normal dosing interval by the dose adjustment factor. Normal dosing interval is the 12 hours, dose adjustment factor is the 0.51. That means 24 hours. So that means you have to give 2 grams of Cepifime every 24 hours if the patient on CRRT. So this is the dosing calculation of the CRRT. Yeah. So there are like different formulas available to calculate the CRRT dosing. Depends on the method of you're using. For CVH, this is the formula Q into F into sieving coefficient by 1000. And if you're using a CVHD, then you need to use the saturation coefficient. If you use the CVH, then you need a sieving coefficient value. If you use the CVVHD, then you need value of saturation coefficient. And if you use the CVHDF, then you need ultrafiltration flow rate and dialysis flow rate, like our case. Then you can use these formulas. These values you'll get it from the standard literature. SC value, SD value, SD value, and ultrafiltrate rate, and you will get it from the CRRT machine. And by using these formulas, you can calculate the clearance of the CRRT clearance. You can use you can calculate the residual clearance. You can apply this total clearance value here, residual clearance value and CRRT clearance. You can apply, and when you apply this dose adjustment factor, you can calculate the dosing factor. You can apply here dosing interval and dose calculation. That's it. Key takeaways: appropriate dosing is a key principle of pharmacotherapy. Identification of patient benefit from the loading dose is very important. Loading dose is not is a static value. It will keep changing. It may be not always 1 gram 2 gram. Use PKPD parameter to calculate the individual dose. MDOs in renal function is very cautious, balance the risk and benefit because of side effects. Pharmacist mastering dosing adjustment is crucial and essential. Thank you.
Thank you so much, sir, for the wonderful presentation. I think the concepts were very clear, and it was like a lot of theory was involved, and you have cleared almost all the basic topics. So thank you so much for that presentation. So I think we'll just have two, three couple of questions. In the interest of time, we may have to wind up soon as well. So just the first question is basically, so you talked about the dose adjustments in AKI conditions.
Yeah.
So there are certain situations when, maybe the creatinine is, maybe the clearance is around 30 to 50, or maybe the clearance is fairly normal. But in certain conditions, the patient may have a reduced urine output. Maybe the hourly urine output is around 10 or 20 ml. So in those situations, do we actually have to adjust the antibiotic dose during the maintenance dose treatment? Or should we just follow the, blindly follow the creatinine clearance alone? Or do we have to look into the urine output?
That depends on antibiotic urine output. If the antibiotic is fraction of antibiotic clearance is more than 30%, that means usually if the clearance of antibiotic in the through the urine more than 30%, usually the guidelines recommend the dose adjustment. So if you have a urine output is very low, that means our antibiotic is not excreting. So we have to calculate usually we see the last 24 hours of urine output, then we can take a call. If the patient of urine output currently is decreasing, then we don't care. Like we will give the first dose. I mean, we'll give the full dose as we assess the next 12 to 24 hours urine creatinine, urine output. Then we can see the how much percentage of the antibiotic excreted to the urine. Then we can take a call.
Okay, sure.
We don't depend on the only creatinine.
Mm-hmm.
We see the urine output next to 12 to 24 hours. We can see the trends of the past serum creatinine and the past urine output. And we can see also any blood urea is increased. And we can see other parameters like the patient on double inotroxia like that. So it's like every time it's like an individual decision. Sometimes we adjust, sometimes we don't adjust. Sometimes we'll keep continuing like 48 hours full doses like that.
Okay.
So we are never in a hurry because there is a like every antibiotic has a particular timeline to cause AKI. The most of the antibiotic they will take at least 5 to 7 days, really cause AKI, and there are really some pseudo AKIs like trimethoprim and piptas, and vancomycin will take at least for 7 to 14 days cause nephrotoxicity. Colistin 5 days. All beta lactams minimum will take to 5 to 7 days after exposure. After first dose of exposure, they really cause like ATN or acute tubular necrosis or acute interstitial nephritis. They usually cause these side effects. So they'll take some time. Sometimes we'll observe that urine routine or something, if they have any sediments and pus cells or any proteins, and then we'll discuss with the nephrologist, are you suspecting any ATN? The patient have a pre-renal AKI, we don't care about adjusting the dose because if you give like good hydration, maybe it will settle. Yeah, so these
Okay.
things like will go by the antibiotic
Mm-hmm.
wise.
Okay. So actually, when you mentioned about vancomycin, so you said it will take around 6 to 7 days for its nephrotoxicity to actually kick
Yeah,
in.
yeah,
So actually, once we had a patient where we started on vancomycin suspecting endocarditis, and then just after initiating the vancomycin, within 1 or 2 days itself, his creatinine just jumped up.
yeah.
So
The
should we have
creatinine is,
actually, yeah.
yeah, the creatinine is jumped up, but see, when you have to know the antibiotic specific drug kidney injury. So usually vancomycin can cause ATN or AAN. So even if creatinine is up, maybe even if creatinine is high, so how much creatinine is increased? Like it is more than 50% from the baseline of the creatinine, and you have increased creatinine, but you can see the pattern of kidney injury.
Mm-hmm.
It's because of maybe the kidney injury because of ATN or because of AN or because of other reason. Is glomerulus okay? But it's a like tubular injury or glomerular injury? You know to talk with your nephrologist. Maybe they'll help you to understand the kidney injury. Then you can take a call. So you really worry about the nephrotoxicity of vancomycin by seeing the urine routine and like some other parameters. Then you can take a call.
Okay. Okay.
So
So in such situations, we need to make sure that what we need to make sure what we are looking into, we need to treat it accordingly and then just
yeah,
take a
you need to know
decision.
that pattern of drug injury
Yeah,
exactly.
pattern of injury.
Yeah, so you
Okay.
need some. We don't always like we're not doing always kidney biopsies to confirm the
Mm.
drug injuries. It's not always practically impossible, and we don't have that time.
Yeah.
So that's why like most of the time the recommendation came to observe the drug use AKI. The usual recommendation they recommending that you see the urine routine for the cast or something proteinuria, albuminuria, or hematuria, something like new onset of oliguria. Suddenly patient went to within hours he went to urea, or like output is dropped, like completely shut down. So that kind of after like minimum exposure of the antibiotic, not 1 or 2 days of antibiotic. Okay. So you can observe these things of you need to write down all these things. You can see like time temporal relationship after starting antibiotic. All these things happen. You have to compare with the previous urine routine, and you're like however like you to go and spend like 1 to 2 hours. You understand these things.
Okay. Okay. So my next question is basically, yeah, so you actually have already mentioned this portion actually in septic patients or in septic shock patients in AKI, that protocol isn't very well defined as to how to adjust the doses because it keeps changing and keeps varying.
Yeah.
But in extremely septic shock patients, like in AKI, we do recommend giving full dose for the first 24 hours. But I have seen the latest articles that mentions that we can give for 48 hours also the full dose. So do you follow any such protocol, or is it this is the 24 hours that we follow? So how is it in your center,
So
the
whatever it
practice?
is, 24 to 48 hours came from, it's not a standard recommendation. It came from like only 2 studies.
Okay.
So usually we see 48 hours, we see that the patient, you don't have any previous AKI. We see the last previous reports. He has a new AKI, we don't care about. And he has a previous admission, he has a history of any infection. And like recently or any previous hospitalization, issued any antibiotic. After starting inotropes, we'll see that after 12 hours also inotrope is not coming down. Is dual inotropes in septic shock. Then the still fluid distribution is going, but still his BP is not improving. Then in that conversion situations will go up to the 24 to 48 hours. There is no timeline to when to give 24 hours or when to 48 hours. The same you can apply the same principles, like that drug injury pattern, and you can see the other infectious parameters like PCT, CRP, ESR, WBC count, and fevers, and something like imaging studies, and talk to your clinician. Like you are sure about this is like really infection, then we'll continue. So sometimes we'll keep 24 hours full dose. Sometimes we'll go up to 7 to 2 hours also full doses.
Okay.
Sometimes we'll come at 48 hours. Yeah, it's like a
Yeah.
24 hours picture to us.
Okay. So
Then
basically, we need
basically
to
beta
evaluate the
lactam.
patient step by
Yeah,
step, and then accordingly we need to take a call.
yeah, we see sometimes hematology of the patient,
Mm-hmm.
any thrombocytopenia, any like neutropenias, hemoglobin is dropping. So generally for beta lactams, we'll try to keep maximum full doses at least neutropenic patients and ICU like septic shock patient at least 24 hours minimum. Then we take a call.
Okay. Okay.
So we
Thank you.
don't find most like the usual recommendation that came from the AK, I mean hyperdynamic sepsis, but in Indian literature, I don't find any patient with a hyperdynamic sepsis. Most of the patients they'll come with the AK.
Mm-hmm.
Maybe in the last 1 week they already have like serum creatinine high. Then for the second episode they'll come to the via tertiary center. They already come with the second 2 3 episodes of AKs already they have. So in that situation, we'll keep up to 24 hours.
Okay. Okay. Thank you. And so what about the pediatric patients? Because we know their kinetics, the parameters changes it's
I
very different
don't,
from the adult patients. So
yeah, I really don't have any experience in pediatrics.
okay, fine. Okay.
Yeah,
Okay. It's okay.
I never worked there.
Yeah, sure, sure. Okay. So I think in interest of time, we may have to wind up this session. It was a very wonderful presentation by you, sir. And thank you so much for answering all the queries. So thank you so much for your time, and thanks to all the audience for your patient listening. So do stay tuned for the upcoming sessions. We'll see you soon. So thank you, sir. Thank you,
Thank you,
FCPI,
Harita.
for
Thank you.
this
Thank you so much.
presentation. Thank you.